Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. Eldon Eichbaum. Dr. Eichbaum completed his medical degree at the University of California, San Francisco, where he also completed his internship and 5 years of neurosurgical training. He went on to complete his fellowship in complex and reconstructive spinal neurosurgery at the University of New Mexico in Albuquerque. Dr. Eichbaum's professional affiliations include the American Association of Neurological Surgeons, the California Association of Neurological Surgeons, the Congress of Neurological Surgeons, and the American Medical Association. Dr. Eichbaum practices at the California Center for Minimally Invasive Brain and Spine Surgery with Washington Township Medical Foundation in Fremont.
So I'm going to try to focus on really the low back pain issues and what affects most of the population. You know, a couple weeks ago, I saw this flyer in the hospital, and I saw this poor gentleman here with back pain, and then I saw my picture on it, and I was like, oh my God, it looks like I'm laughing at this poor guy, and I'm not laughing at him. I know he has back pain, and I'm very empathetic. In fact, I actually had a back surgery about 20 years ago when I was in my training in neurosurgery. And so I know what it feels like to have back pain and leg issues, and so I can empathize with anyone that has it here in the room. Now, and the other thing is that if I actually had the cure for back pain, I probably wouldn't be here. I'd probably be on an infomercial trying to sell it to somebody and make a lot of money. But you know, back pain, again, is a difficult thing to treat and very multifactorial. So I'm going to start off by just going over what we're going to talk about today. So the epidemiology, you know, how frequent is it? Why do we see it? Then go over the anatomy, and then also the signs and symptoms that people complain about when they come to see me, and then what I look for on an examination. Afterwards, the next step is usually to look at scans or studies, imaging studies, whether they're x-rays or CAT scans, MRI scans, and then go kind of over the treatment. And this talk is kind of focused mainly on, from my standpoint, so I'm not going to only talk about surgery, but basically I'm going to emphasize kind of what I do and what we can do for back pain from the surgical standpoint. You know, low back pain, as I said before, is a very common problem. It's the second most common cause of people not going to work behind the cold. And so you can see it affects a vast majority of the population. About 80% of our population will experience some type of low back problem, low back pain in their lifetime, which is the majority of us in the room. And about 10% of that population will have developed chronic back pain. So it's a significant amount of people. You can think about the United States has over 300 million people. You know, 10% of those people are going to have back problems. Now, whenever a patient comes to see me in the office, they ask me, is it genetic? Can I get it from my parents, or will I give it to my children? Well, we do know that low back pain is multifactorial, meaning it can be from many causes. So I can't say that you can get it genetically, but there are studies that have shown that one of the causes of back pain, or degenerative disc disease that we think causes back pain, does have some genetic component. And so people can develop more frequently or earlier degenerative disc disease in their spine, and that may cause back pain, and you can get that from your family members. Another reason why people may have some issues with pain more than others is that everyone is innervated differently. And so you can have more pain fibers than somebody else and therefore become more sensitive to certain issues. And therefore that could be one cause of developing back pain with someone who has significant abnormalities and someone who doesn't. So let's just go over the anatomy. So what the spinal column basically is our way of keeping us upright in our walking position, in our walking ability to walk and to stay upright. And the reason that we have the spinal column is not only to help us in our upright position, but also to protect the neural elements that innervate our body for the muscles, for strength, the skin for sensation. And so the bones of the spinal column are there to protect the nervous tissue. And if you look at the spinal column, it's arranged in a manner where you have cervical vertebrae, which is the neck or the C-spine, where there's 7 vertebrae. Then comes a thoracic spinal column, which is from the neck to the lower back. And then the next level down is a lumbar spine, and that's called the L-spine. And that's what we're going to focus more on today. Now, there's an anterior part of the spinal column, which is the front part, and there's a posterior part. And in between is the spinal canal, and that's where the spinal cord and nerves run. And they exit from either side to innervate the arms and the legs and other body parts for functioning. So in the anterior part if you look at one vertebral body, a vertebrae, or one segment of the spinal column, the anterior part is called the vertebral body. And that's where most of the weight of the spinal column goes to. Behind the vertebral body is where the spinal canal rests and where the spinal nerves and cord rest. And behind that are the lamina. So the lamina is the bone that protects the back side of the spinal cord. The vertebral body protects the front part of the spinal cord and the nerves. And then they're connected by something called the pedicle, which connects the front part of the spinal column to the back part of the spinal column. Okay? The joints, the facet joints, are the articulating surfaces which allow the spine to move in different directions. So forward, backwards, left or right. And these are all important structures to kind of keep the spinal cord and the nerves protected, but also allow us, again, to be in an upright position. Normally, the cervical spine or the C-spine has a curvature that is called lordosis, which is a lazy C curved backwards. So if you see me standing upright here, it doesn't look like my neck is curved back, but if you took an x-ray of me, the normal posture would be that my neck looks a little bit curved in this projection, like, and if you look at a board, it'd be like curved back like this a little bit. And you'll see that on some x-rays. And the thoracic spine, or the mid-back, has a curvature that is slightly forward, and that's called a kyphosis. And the lumbar spine, which is the lower part of the lower back, or the L-spine, is again in lordosis. And the way that we've been made to have balance with upright positioning, you want to have that in such a manner where the cervical spine is in lordosis, the thoracic spine is in kyphosis, and the lumbar spine is in lordosis. And if there's any perturbation or change in that alignment, that can cause symptoms of back pain as well. There's one other thing I didn't mention here are the transverse processes, and these are part, again, of the vertebra, that unit that allows attachment of muscles to the spinal column. So we have the bone. Now there's also soft tissue, and the reason that the spine stays together and doesn't move too much and is also stable is because of the soft tissues that are included in the whole spinal unit, and that includes the discs, which are what separates each vertebral body. So if you think about, and I'll show you in a minute on some cartoons, the vertebral bodies are stacked up on each other like blocks of bone. And they're separated by the discs. The discs are I like shock absorbers. They're kind of a more rubbery type of consistency and allow for cushioning other vertebral bodies and also allow for some stability as well. And whenever you hear someone, I got a slip disc, I have a herniated disc, that means that part of that disc has come out and is compressing the nerves. okay? There's two components of the disc. One is called the annulus fibrosus, which is the outer portion or the wall, and the inner part is called the nucleus pulposus. And if you have, let's say, a disc herniation, the annulus has a weakness in it, and part of the nucleus bulges out and pushes backwards into the spinal canal and can cause nerve or spinal cord compression, okay? Now, in order for all these bones and discs to stay together and not just fall apart, you need ligaments. And there are several different ligaments that are important to keeping this whole spinal unit intact. But the most important ones are these three here. The ALL, which stands for anterior longitudinal ligament, the PLL, or the posterior longitudinal ligament, and the ligamentum flavum. And the reason I'm just mentioning this to you is that because these are also possible pain generators, which we'll see in a minute, but also very important in the stability of the spine and are causes, as you'll see later on, of symptoms. For instance, the ligamentum flavum, this is the ligament that is on the roof of the spinal canal or just below the lamina, which again I'll show you in a minute. And if that overgrows or hypertrophies, that can cause narrowing of the spinal canal. The anterior and posterior longitudinal ligament, they run on the front and the back of the vertebral body and help stabilize that as well. And if those things are injured, let's say in a traumatic injury, that can cause someone to have significant instability of the spine and require major surgery. So those objects we talked about are kind of protecting what's here, the nervous tissue. The meninges are the covering of the nervous tissue. And there's three layers, but the major layer that we talk about in general is called the dura, which is the outer layer and the toughest layer. And that covers the spinal cord and the brain and allows for circulation of the CSF, or the cerebrospinal fluid, which helps with nutrition of the nervous tissue as well as with helping with protecting it. And so the dura, when you hear someone says, oh, I'm going to have an epidural injection, what they're talking about is they're localizing the injection to the dura, which is the spinal sac, and epi means on top. So I wanted to mention that the dura is what encases the spinal cord and nerves. And finally, the spinal cord, obviously we talked about, and the nerves. The spinal cord is a cord of tissue that has all the nerves that run from the brain and then enter from the skull down into the neck. So the brainstem becomes a spinal cord right at the upper part of the neck, and it travels down all the way to the lower part of the thoracic spine. But most people don't know this, is that the spinal cord actually ends right around T12. So there's 12 thoracic vertebrae, and then after that starts the lumbar vertebrae, which are 5. And the spinal cord ends around the T12 area. But we have all these nerves that come to the legs, and you think, well, what happens? Well, at that level, the spinal cord becomes what we call the conus. It tapers off into a little cone and gives off nerve roots, which are called the cauda equina, because if you look at it, it looks like a horse's tail. So those nerves are the nerves that become the nerves that go to the legs and to the sacrum and to all these areas below your waist that innervate those areas for sensation, for function, strength, and so forth. And I don't know if you've heard of someone, maybe someone heard of this, there's something called cauda equina syndrome, when if the spinal cord, the nerves are compressed severely in the lower back, that's what that is, okay? So if you look at just a cartoon here, you'll see that when we look at scans or x-rays or imagings, there's usually two or three or four views you look at. One is called an axial view. The axial view is kind of like a view that we look from the top or the bottom. And this is an axial view. And if you look at this, and when we see scans later on in this talk, the axial view is, you can imagine someone laying flat on their back through the screen, okay, with their head through the screen, their feet coming out this way. It's almost as if someone's like being a magician, in one of those magician tricks where they're on the table there and they're going to saw them in half. Well, that's what we're looking at. We're kind of looking at them that way, and we're sawing them in half and then looking up from the bottom up. So in most scans, you'll see that this is the left side, this is the right side of the body, of the screen, the left side of the screen here. But when you look at a CAT scan or an MRI scan, which I'll show you later, it'll be opposite. But in general, this right here is a cartoon of a vertebra. anterior part or the front part is here. That's called the vertebral body. The posterior part is here. These are the lamina here, which makes the roof, and here's where the spinal canal is. This is where the spinal cord and nerves lie. Okay? What connects the anterior part or the front part to the back part are the pedicles. And when you see later on, when we put instrumentation in the back, like pedicle screws, what we're doing is we're placing screws through this pedicle into the bone here. So it's always in bone and not in the spinal canal. The spinous process here is just an extension of the lamina, and that's the points that you feel on your back when you feel touching the middle part of your back. That's the spinous process here. And then here are the transverse processes here, which are what a lot of the muscles attach to. And then the facet joints are right here, and that's what allows the vertebral bodies and vertebrae to connect to each other. Okay? Now this is an axial view of a disc. So again, so here is the middle part of the disc called the nucleus, and here's the outer part called the annulus fibrosus. Okay? Now the other two views we look at are a sagittal view or a side view, and I tell my patients when I see them, the way I try to explain this view is that you think about yourself standing sideways, and then someone cuts you right in half in the middle, and then we look at you from the side. And this is what we're seeing here. So this is a side view showing the bones stacked up like blocks, the vertebral bodies here, the discs here in between, they're like shock absorbers, okay? And then the spinal cord is me running up and down this way, okay? So here, the head would be here, the feet would be down here. And here's the back side here, and you see the spinous processes back here, which again you can touch right here. And these are called the foramen. And what is a foramen? Well, the foramen is where the nerve exits out of the spinal canal to go into the body to innervate the skin for sensation, the muscles for strength, and so forth. Okay? And this is the last view, called a coronal view, which we're not going to see a cutaway, but this is basically a front-back view. So it's if you're looking from the front or the back. And in this particular case here, you're looking from the back, and you see the lamina here. And I just wanted to show you this cartoon here just to show the ligaments. So all the bones were together. Now, this is the anterior longitudinal ligament, which runs right in front of the spinal column on the anterior or the front part of the vertebral body. Here's the posterior longitudinal ligament here. And this is where the spinal cord is going to run. And then here is that ligamentum flavum, which again creates the roof of the spinal canal. Okay? And there are other ligaments which I won't mention, but you can see here. And then this is now the coronal view, again, the front-back view, if we cut away the backbone and just looked at the front bone. So what causes back pain? Okay, and again, we talked about there's many things that can cause back pain. But most commonly, if you develop back pain, there's some type of trauma related to it. And I'm not talking about a major trauma, but most people say, you know, I bent over and I lifted something and I felt a pop in my back. Or I was twisting and I was bending and something developed. And many people, it doesn't occur right away. They'll say, you know, I bent over and I had no problem, and like 5 days later, I developed a lot of this pain. And I can't tell you exactly why that happens, except what I think most likely happens is that you've injured yourself. Let's say that you did something and then 5 days later you have symptoms. You probably caused maybe a small tear in the disc wall, which wasn't a problem, and then as you've done your usual activities, some disc may come out at that time and then cause more symptoms. There are other things that can cause back problems, and you know, just like minor things like sneezing. And more significant things like falling off a ladder or being involved in a motor vehicle accident. You can have a wide range of injuries in those kind of accidents. But those major ones, like falling off a ladder or a motor vehicle accident, they usually cause fractures, which we're not going to talk about today, but that can be one definite cause of back pain. But there are a lot of people that are in motor vehicle accidents which are not as major, but they develop a lot of pain afterwards, and there can be, again, a lot of things that can cause the pain, whether it's ligamentous injury or disc protrusions or just muscle injuries. So when a person comes to my office and starts telling me about their symptoms, I ask them several things, okay? Like, for instance, what causes your back pain? So if someone tells me, I have a lot of back pain, and I ask them, do you have leg pain as well? Okay? And why I'm asking about leg pain? Well, I'm looking to see if there's some nerve irritation. There's something called radiculopathy, which just refers to nerve. So radicular means nerve. So if you have a radiculopathy, there's some nerve irritation. And that can manifest either by pain down the leg, numbness down the leg, tingling, weakness in the muscle groups, or any combination, sorry about that, any combination of that. And because that it's important to know, because if patients have significant symptoms of that, they may require a more urgent type of treatment, okay? But most people have back pain, and many people have leg pain, and you have to kind of decipher what their symptoms are. In the younger population, people that have disc herniations, their major symptom is they have back and leg pain, and it's usually worsened by sitting. And why is that? Well, because when you sit down, you put more stress on the disc. It may bulge back a little more and cause symptoms. When they lie down, they feel better. Why? Because you're taking the weight off that spine. And in most people with back symptoms, lying down makes them feel better, okay? If in the older population, many people will say, you know what, when I stand up and I walk, I develop back and leg pain, but if I sit down, it goes away. And that's pretty classic. That's a classic diagnosis of neurogenic claudication. What does that mean? Well, neurogenic claudication means, number one, claudication means pain with activity, okay? And it was first diagnosed with vascular problems or blood vessel problems. So if there's poor blood flow to an organ, let's say the muscles in the leg, because there's clotting of the blood vessels that go to the leg, people would develop pain with activity like walking. And if you stopped walking, the pain would go away because you're not requiring oxygen to be given to those muscles. With neurogenic claudication, they have the same symptoms, but that's because the nerves are being compressed. And so more commonly in the elderly population or the older population, as the nerves slowly get compressed, they don't have any symptoms until they get to the point where they can't tolerate it any longer. So you have something called neurogenic claudication. People stand up, they walk, their spinal canal is narrowed. It causes some poor blood flow to that area as well. And if they stop walking and sit down, it goes away. Or a lot of people tell me, you know what, if I go to a store and I push the shopping cart and I bend forward, I feel better. Again, I'm thinking at that point, again, neurogenic claudication. Why? Because when you flex your back forward, that opens up your spinal canal a little bit and gives some relief. And when you stand up and you're extended a little bit, you narrow the canal, and that's why they have complaints of that. So whenever someone comes to me, I'm always thinking, trying to figure out and pinpoint where their problem is. If they tell me they have numbness in a certain distribution, like it goes down to the outside of my leg, I'm thinking like the L5 nerve in the lower back, because that's the area that's innervated by that nerve. Or if they say, you know what, my foot flops when I'm walking, well, I'm thinking about a foot drop. And again, what causes that? Well, usually the L5 nerve innervates the muscles that cause you the ability to raise your foot, and therefore, I look at that, I'm trying to think that's probably the level that's causing the problem. So when someone comes to me after I get the history and I'm kind of thinking what's going on, the next step is an examination. And you know, people come in with varying degrees of pain and problems. Some are symptomatic right then, some are not at all. And so the people will be talking to me sometimes in the chair, and other people that come into the room and they're laying on the table in agonizing pain. In any event, I look at that first. And then I want to look at other things that could be possibly give me an idea what's causing the problem. So I usually palpate the back and look at someone's back and see what it looks like when they're standing. Is there some abnormality in their alignment? Like, are they flexed forward? Or do they look twisted, like for scoliosis? Is it tender to touch when I push on there? And in many people, if they're tender to touch, then one of their problems could be that they have either an infection or a fracture. That's more commonly seen in people that have problems like that. In people that have chronic low back pain, it's not that common to be tender to touch when you palpate. And then the neurologic exam is looked at very carefully because, again, that's a very important factor to seeing how urgent something needs to be done. If someone has significant weakness on their motor exam or strength, they can't lift their foot up, then I'm more concerned. If it's more that they have pain, I'm empathetic, but I'm not as concerned that something has to be done emergently or urgently. So we look for sensation, again, for strength. Again, because those nerves innervate the skin for a certain part for sensation, motor, and the muscles for strength. And we look at reflexes as well. If one reflex is less than the other, it can kind of guide me again to where I think the problem could be. A straight leg raise is done, which we have patients lying on their back, and then we raise their leg up, And if it causes pain, that indicates nerve compression. And again, I forgot to say this, but people, when people complain of leg pain, it's called sciatica, right? And what does that mean? Well, the sciatic nerve is the major nerve that runs down the leg that's made up of several of the nerves from the lower back that come out and then make one big nerve. And that's another indication people complain of sciatica. That's what they're talking about. I also look at their ability to walk. Are they limping? Can they stand on their heels or their toes? And again, that lets me know if there's any weakness in a certain distribution. Now, there are other causes of back and leg pain that we talked about. One was vascular, for instance, claudication, vascular claudication. They have pain with walking due to poor blood flow to the legs, but also other things like joint pains from the knee or the hips. And by examining someone, you can kind of usually rule that out, okay? This cartoon, even though it's sideways, it shows what I want you to show is that this is the innervation to the body. In general, most people will focus on the legs. You can see that it says it has L1, L2, L3, L4, L5, and the S1s to 5. These basically show where the particular nerve innervates the skin for sensation. So if someone comes to me and says, look, I have numbness on the outside of my calf, well, I'm thinking it's probably from the L5 distribution. Okay? So I'm looking, well, there's probably a problem at either the L4-5 or the L5 S1 levels, because that's where those nerves are mainly exiting. So now we come to the part, well, what causes the back pain? Why do we have back pain? And again, as I said before, there's so many reasons you can have back pain, but I'm going to focus on more the degeneration and the more common causes of back pain. So the most common cause that we think is degenerative disc disease. And what does that mean? It's not a disease like diabetes. It's really just the aging of the spine. And when we're young, in our teens, 20s, and 30s, we have nice, plump, hydrated discs, okay? And as we get older, those discs lose their water content. They kind of shrink down. And they get what we call annular tears, which means that there's some tears in the annulus, which is the wall. And we believe that that process can cause pain. As also those discs shrink down, they kind of pull on the edges of the bone that's above and below, and that causes the development of bone spurs or osteophytes. And those can cause pressure on the nerves, which we'll see a little bit later, and also cause some irritation to the innervation of those areas, causing pain. The facet joints are the joints that allow for movement of the spinal column, and therefore they can be either looser than normal or overgrown, and because of that we believe can cause pain. The ligaments can cause pain, muscles can cause pain, spasms, and it's hard to know what came first, the chicken or the egg, for instance, with muscle spasms. Is it because there's pain and you're getting spasm, or are you having pain because of spasm, or both? But both can happen. And then you look at other reasons like deformity. And again, with the scoliosis, if we got x-rays on everyone in this room, I can guarantee you that a significant portion of people are going to have scoliosis. And although most people, we don't think scoliosis causes symptoms, it can, especially as the curvature gets greater. And when I talk about scoliosis, I'm talking about a curvature of the spine in the front plane. So if you see someone standing in front of you, they're curved either this way or that way, okay? And then sagittal imbalance is talking about the ability, like I spoke about earlier, about the spinal balance itself in the front back plane. So if you have sagittal imbalance, either you're too far forward or too far backwards. And as we get older, and as the discs degenerate, the spine tends to lose the curvatures in some areas and exaggerate in other areas. So, for instance, in the cervical spine, usually there's a curvature that's backwards called lordosis, so like this, for instance. But as we get older and those discs degenerate, our neck tends to straighten and sometimes go forward. And as that kind of goes on, the mid-back, the thoracic spine can also do that, and we tend to bend forward as we get older. That adds stress to the lower back and causes back pain as well. And sometimes, to correct that, needs a major operation. Other causes of back pain that are more understandable and are easy to understand why they cause back pain are fractures. And there are two major types we think about. One is just an osteoporotic fracture, meaning people that have soft bones, especially when they're older, they can fracture and have what we call compression fractures, or traumatic fractures where people have significant injuries and the bone kind of bursts. And I'll show you a case of a compression fracture in this coming up. Also, infections can cause significant back pain, which I won't talk about now, but people that have infections can have significant pain in the back. It's very severe and very dangerous and needs antibiotic treatment urgently. And then tumors can also cause pain. And again, depending on their symptoms and what their scan shows will dictate how to treat them. This cartoon shows that there is innervation to the disc itself, and therefore we do think that the disc can cause pain. And again, how much of it is causing the pain is difficult to know, and it's hard to read in everybody. But in general, you see here's an axial view, again, a top view, we could say, of the disc. Here's the annulus here, here's the nucleus in the middle here. And you can see that here's a nerve coming out of the spinal canal and going down to the leg somewhere. But off that nerve are these little tiny nerves that are coming and innervating the disc. You see here and here, okay? And this is just a view which shows the nerve, which is, let's say, a long tube-like structure. It's being cut right in half. So you're seeing this cut right in half. This is the L5 nerve, and this is where the disc is. And these are the other nerves that are distal, or that go farther than the L5 nerve, and that are about to come out farther down. But you can see as this exits out, this nerve here, the L4 nerve, it gives off all these other branches to innervate the disc. And so if the annulus has a tear in it, it can cause irritation of those nerves and cause pain. This cartoon here just shows again that you have innervation from these nerves to the facet joint as well, and therefore the facet, or that joint, can cause pain. And a lot of times treatment is guided to that area as well. This shows that the alignment of the spinal column, we just talk about the balance of our bodies. In the middle, this is a normal balance. It doesn't show the cervical spine here. It would be curved back like this, but you can see here's the lordosis, or the curved back of the lumbar spine. Here's a slight curve forward of the thoracic spine. But the normal balance in the sagittal plane, or the side plane, if you drop a plumb line from the mid portion of the C7 vertebral body, which is right here, and you just drop a line down, it should hit the back end of the sacrum, the top part of the sacrum, okay? And the sacrum is that bone that's just below the lumbar vertebrae. If that's abnormal, if you somewhat flex forward here, you see that it's positive, or it's what's called positive sagittal balance, and that can cause back pain. This cartoon just shows all the forces, or many forces, that are applied to the spine all the time, and how you can have injury to them. For instance, if this twists and bends, you can see how some disc can pop out and cause pain. Okay? So before we go on, I just want to talk about a couple of definitions to make sure that you understand why we, in general, operate on patients. The major reason and the best success rates for operations are in patients who have stenosis. And what is stenosis? It just means narrowing of the spinal canal. Okay? So the diameter of the spinal canal gets narrowed, and that's either from a combination of a disc bulging backwards, or bony spurs from the disc space bulging backwards, and the joints, the facet joints, overgrowing and pushing forward with hypertrophy or overgrowth of that ligament, ligamentum flavum. So all those, the combination of all those things can cause narrowing or stenosis, okay? And there also can be narrowing where the nerve goes out, which is called the foramen, or the foraminal stenosis. So you can have central stenosis, which is in the center of the spinal canal. You can have lateral recess stenosis, which means on the outer part of the spinal canal. Or you can have foraminal stenosis, which is where the nerves exit. The next term is spondylosis, and that's basically just defines the degenerative arthritis of the joints and the disc of the spinal column. Just like we talked about earlier. Discs, they lose their water content, they shrink down, they cause the development of bony spurs, the joints can overgrow. All that means spondylosis, okay? And then finally, spondylolisthesis. The longer the word, it's very difficult to pronounce these words, especially for me too. So spondylolisthesis just means anterior or posterior displacement of one vertebra on the other. So if one is slipped in front of the other, that can denote some instability of the spine. And this is one of the better reasons to consider a fusion, one of the procedures that we do, okay? Because if you have one bone that's slipped on the other, not only does it cause instability, or it denotes instability, that there's some, and that can cause back pain, but usually by slipping one bone on the other, it causes also narrowing in the spinal canal and where the nerves go out. Because you can imagine if you have bones that are stacked up on each other and you slip one forward, it's going to cause a difference in the canal diameter. So this is just a schematic just showing a normal spinal canal here. Again, the vertebral body in front, the posterior bones in back. Here's the facet joint. Here's a nice circular diameter of the spinal canal. As we get older, the disc bulge backwards, the joints overgrow and bulge forward, and the ligament here bulges forward. You can see it gets narrowed, okay? And that's stenosis. And you can get that also here in the foramen where the nerve comes out. So once I've done all the history and examination, the next step is imaging studies. And everyone wants to jump up and get an MRI scan. And that's true. It's probably the best study that we can get to view everything. But plain radiographs or x-rays and CAT scans are still extremely important in evaluating a patient. Why do we do x-rays? Well, first of all, it shows me the alignment of the patient. It shows whether they have scoliosis, whether they have a spondylolisthesis. Is there a lot of degeneration of the discs? When they're standing up, patients that have an MRI scan, they're laying down. But if you're standing up, it can show when you're weight bearing, is there a slip of one bone on the other, which you may not see if you're lying down. So they're very important still. It can also show if the person has osteoporosis, a mild fracture. All these things can be gotten very quickly. You don't really, another thing to look at is that most insurance companies don't need approval for that, so you don't have to wait days to weeks to months to get them. It can give me an idea of what's going on. They're very important. And we get AP and lateral, which means anterior, posterior, so front view, and lateral means side view. And then flexion extension views to see if there's any bone moving one on the other, okay? And then the 36-inch view is one to look at the whole spinal column that looks from the top of the neck down the tailbone. And that allows me to look at whether there's a significant scoliosis or imbalance in the sagittal plane. What's the next study we can look at? And that's one again, is a CT scan. What's the CT scan best for? Well, for bone anatomy. So it can look and show how bad are the bony spurs there, if there's any significant overgrowth of the joints. It also helps when we're performing a procedure such as a fusion to help plan with placing of the instrumentation, or if you're having to remove a bone and what has to be replaced there, it helps with the planning. But you know, if you had to get one study, the MRI scan probably shows you the most with one study. It's the best study to look at anything acute or soft tissue, okay? So disc herniations, degeneration of the discs, it can show tumors, infections, all those things. But it also shows the spinal cord and the nerves, and if there's compression of either of those things by a disc or ligaments and so forth. So this is an excellent way to evaluate the spinal column. This is just a X-ray. On the left is an AP view or a front view, and here's a lateral view on the right side of a pretty normal-looking lumbar spine or L spine. Okay. How do I know we're in the lumbar spine? Well, we see the sacrum, and this tells me where I am. So if this is the sacrum, the top part of the sacrum we call S1 for sacral segment. There's 5, but they're all fused together, so they're kind of hard to count. You can see them on an MRI scan better. But the bones in the lower back, you count from highest to lowest because you're starting at the bottom. So this is S1, this is L5 or lumbar 5, 4, 3, 2, and 1. And this is T12. And the discs in between the bones are named for the bone above and below. So this disc here would be L4-5 because this is the L4 and L5 bone. You can see here there's a nice lumbar lordosis here, curved backwards a little bit. And here they're straight up and down. Okay? Now these things here are the pedicles, which we see right here as well, and that's again what the screws go through to hold the spine in place. Now this is just a person who's got a little scoliosis. You see the difference? You see here on the right side, the front view, you see how instead of going straight up and down, there's a lot of degeneration of the discs. They're asymmetric. And whether that's causing this individual's pain or not, I can't tell you, but this is just an example of scoliosis. And you can see here on the lateral view, because of the scoliosis, when they're taking a side view, it's hard to even see the bones stacked up like you usually see, right? And also, this person has some osteoporosis. So this person has a lot of different abnormalities on just the plain X-ray. This tells me a lot right here, okay? This now is an X-ray of a side view or a lateral view, which shows the bones stacked up like blocks. But what I'm focusing on here is the spondylolisthesis. You see how This bone here, the L4 bone, is in front of the L5 bone, and this person is flexing forward here, which increases that slip, and when they extend back, it goes back to relatively normal. So that is definitely someone who has a little bit of unstable joint, and that could be a cause of their pain. Next imaging modality is a CAT scan, and this, again, the CAT scan is basically it gives the views of axial views, the view cut like in this plane. Again, if the person is lying on their back through the screen, like floating in the air, on their back, their head through the screen, their feet coming straight back at you, and we slice them in half that way, this is what we'll see. And when you look at a scan, the right side of the image is actually the left side of the body, and the left side of the image is the right side of the body. And so here's the vertebral body in front. Here's the spinal canal here. Here's the transverse process. Here are the facet joints here, the lamina, and the spinous process. And this shows a pretty normal looking vertebral body, or vertebra, okay? This is just and as you get a CAT scan, they make slices, put it up here, and then go another 3 to 5 millimeters and make another slice. And eventually, this is another view, but showing at the level of the disc space. So here's the disc. The disc doesn't really have any radio opaque marker, so it looks a little bit like it's somewhat bone. And then here are the joints here on the left and on the right. So left side, this is the left side of the body, the right side of the body. And here's where the nerve exits here and here. But you can see, I can't really see discs. I can't see the nerves, the spinal cord. So this is not an ideal study to look for that. But if they had a fracture, we could see that, and I'll show you in a minute. This is an example, an axial view again, a CT scan at the disc space of L4-5 marked by the radiologist. There's some disc bulge here, but again, it's not a very good view of that. But you see this person's joints are arthritic and overgrown, okay? And so there's most likely stenosis or narrowing there. This is an example of a fracture. You can see that it's kind of obvious as a fracture there. The bone is kind of split in several areas. The spinal canal is narrowed by at least 50% because of this bone pushed back in the spinal canal, okay? And when we do CAT scans, they do mostly axial views or cut in this plane, but they can use the computer to reconstruct it into a side view or a sagittal view or a front view, the coronal view. And this is an example of a fracture in the sagittal view. You can see, normally you see the bones stacked up like blocks. Here are the discs. Here's the spinous processes. And here's an obvious fracture where it's fractured and the bone is pushed back. And this is a traumatic fracture. And finally, the MRI scan, okay? Now, you can see it's got it looks a lot sexier. There's a lot of stuff you can see here, right? And this is a sagittal view, so a side view. And what you see, again, we look to see where we are. Here's the sacrum, or S1. So I know this is L5, L4, L3, L2, and L1. The discs you can see here on this study, that looks normal, those nice, bright, plump discs, okay? This is a relatively young man. But here you can see there's some degeneration occurring at this disc. Why do I know that? Well, it's not as tall as the other ones. It's blacker. And you can see a disc herniation here. You see there's a disc pushing back here. You also see the spinal sac here, and the white in this particular view is the spinal fluid, the CSF. The nerves are these dark strings coming through, and you can see that normally the spinal canal should be, let's say, this diameter. It's significantly narrowed at this level, so that's called stenosis, okay? This is now an axial view, the same view that we saw with the CAT scan, where you see a disc in front of the spinal sac. Here's the spinal sac. The dots here are the nerves. The white is the fluid. Here's a nerve exiting at that one level on the right side, on the left side, and here's the lamina on the back side. And these are the muscles that surround the back side of the spinal column. And here's that level where there's a disc herniation. You see there's a pretty big disc herniation, and it's causing that spinal sac to go from round to almost like a pancake shape, okay? So that's when you see it. That's when you see a disc herniation, okay? I'm going to show you a couple other examples of some progressive degenerative disc disease on the MRI scan. You can see this patient here. What I want to show you here is that, again, I look here. I found the sacrum here. I kind of cut it off with a picture, but here's the sacrum. This is L5, L4, 3, 2, and 1, and here's T12. And I show this because it shows you the spinal cord coming down, and it suddenly ends here. But it gives off all these nerves down here, which are called the cauda equina. They're floating in the spinal sac called the dura, and the spinal fluid bathes it. And you can see there's varying degrees of degeneration of the disc here. There's some there's some disc degeneration here, not too bad here and here, but as you go down farther, you can see it gets more significant. And the most common levels that are affected by degeneration and aging are the lowest two levels because the lumbar spine is very mobile. And all the years of us moving around and jumping up and down and bending and twisting adds stress at these levels, especially the lowest two levels. And therefore, the most common levels that are affected and that I see that need treatment are the lower two levels. This is just an axial view, again, a top view from the same person, showing that I can just tell you this person had a previous laminectomy because there's bone is missing here. The joints are overgrown, and the disc is here. Here's the spinal sac, the dots of the nerves, and there's a disc bulge towards the left, and that person could have left leg pain, okay, but may have no pain at all either. So again, I'm assuming that since the patient came to me, they probably had pain, but you'd be surprised. This is another, again, showing a more significant degenerative MRI scan of disc disease here, showing that almost every level has degeneration of the disc. Here's the sacrum, here's L5 and S1, and you can see at L4-5, there's a slight slip of the bone of L4 and L5, which you would probably see worse on a plain X-ray if the person stood up. And you can see also that there's narrowing at several levels, especially this level. And this is now just the axial view of the same patient showing that level where there's a slip of the bone, the spondylolisthesis. You see there's disc bulging backwards. There's significant overgrowth of the joints, and the narrowing of the spinal canal is significant. And here's now just another example of a person with straightening of the lumbar lordosis. The patient's low back is straight. Every disc is abnormal. But I can just tell you that this person may have no pain at all. And that's why it's very difficult to treat back pain, because just because you have degenerative disc disease doesn't mean you're going to have back pain. And let's say this person does have back pain. How do I treat it? I mean, what am I going to do? Am I going to fuse every level in this person's spine? I think that's not very successful. So this is a more complicated problem to take care of because it's rare that you can take care of someone who has all these problems unless you can localize their pain to some level, okay? And this is one last view just showing again a spondylolisthesis here, a slip of one bone on the other, and on the axial view showing very large joints here that have developed over time, and then narrowing of the spinal canal. And finally, this last MRI scan I'm going to show you just shows you that fracture that we saw on the CAT scan before. You can see pretty well here, there's significant fracture of that bone. Here are the other bones which are normal looking. And you can see there's significant narrowing of the spinal canal. Luckily for this person, the spinal cord ended right above that area. So the nerves that come off the spinal cord or the cauda equina nerves are much more resilient than the spinal cord itself. So that's why people that have neck injuries or back injuries that become quadriplegic, they rarely recover, okay? Because the spinal cord is not very resilient to injury. But the cauda equina nerves are more resilient. And so people that have injuries that are below the spinal cord ends have much better chance of recovery. So treatment, how do we treat this problem? Well, again, I'm a surgeon. I generally treat people non-surgically because most people don't require surgery. We always start with the simpler things. And what is that? Well, we know that non-steroidal anti-inflammatory medications are the NSAIDs, like ibuprofen, Relafin, Celebrex. They're pretty good. They work pretty well and they're pretty safe. Okay? So that's usually what we start with. Or Tylenol. And in most people, that takes care of their problem. Now, for patients that have significant pain, you know, we can try narcotics, and there's a slew of those medications you can try. And you know, I usually start out myself with either Norco or Vicodin or Tylenol with codeine, but you can ramp up significantly. But there are a lot of issues and problems with that, especially as we get older, we get a lot more side effects of those medications. Antispasmodic medications, I tend to use Valium because it seems to calm the muscles well. But there are other ones like Flexeril or Soma. But all those medications can cause side effects. You have to watch out when you take them, especially, again, as we get older, a lot of people are on a lot of different medications, and it adds to their list. And then finally, the medications for neuropathic pain. What does that mean? Well, there are other medications that we have discovered have helped with pain, whether it's leg or arm pain, and it didn't come out for that reason. Neurontin, Lyrica, I don't know if you heard those medications, but they came out for seizures, but they've been shown to relieve nerve kind of pain. There's some antidepressants like Cymbalta, Elavil, which again have been shown the same thing. So you can try those medications, and frequently they can work. Again, they have side effects, you have to watch out for them. The next step is usually physical therapy. And you know, why does it work? You know, I can't tell you why it works. but in a lot of people, it does a great job. There's passive range of motion, there's active range of motion, there's exercises that they do, and all that strengthening of the core muscles and the muscles for the back helps support the spine and most likely helps people with their pain. The tincture of time is one of the major things. Like just time, the body eventually heals itself, okay? And no matter what you have done, whether it's what you've done or not, the body is trying to heal itself in general, okay? And people ask about chiropractic care, and I think that I've had a lot of patients that have done have had a great job with chiropractic care, and I think you should definitely try chiropractic care. The only thing that I warn anybody about any of these treatments is that if they cause you more pain, I would stop doing them, okay? So, and then there are other treatments, a lot of other treatments people try that are a little bit off the beaten track. I mean, like yoga, Pilates, Rolfing, all these different things are available. And again, you definitely can try them. And if they don't work, or if they cause pain, then stop doing them. Once you've tried these things, they're not better, or your pain is so severe, the next step is injections. And what are the injections? Well, the injections are just a medication it's an injection of usually some lidocaine, which is a anesthetic, a short-term anesthetic, which gives you a little relief initially, in conjunction with a steroid, cortisone, okay, or prednisone. And what is that medication? Well, that cortisone is a very potent anti-inflammation medication, and that can help with inflammation and pain relief for quite some time, for days to weeks to even a couple months at a time. And all these names of these injections are just a location where the injection is placed. So an epidural means on top of the spinal sac, okay? A nerve block means you inject the nerve where it comes out the spinal canal, okay? Facet block just means you're injecting the joint, the facet joint. And then a rhizotomy is actually not an injection of steroid. What it is, in patients that have done well with facet blocks, if they have, let's say, overgrown facet joints, and that maybe we think that's the cause of their pain, and they get better with a facet block, we do a rhizotomy, which is basically using a high frequency or radio frequency lesioning or heating up a probe on the nerve that goes to that joint and kind of eliminating that nerve and hopefully helping give you a longer term relief of that pain if it's from that joint, okay? If those things fail, then surgery can be considered. But again, I caution anyone from proceeding with surgery unless they have several things that go together. And that includes symptoms that are consistent with their problem, a scan that goes with their problem, and an examination that goes with their problem. When I say that, I mean if someone has significant back or leg pain and they have a nerve being compressed and their exam is consistent with that, and the MRI scan shows a disc herniation at that same level, then you've got a much better chance of getting better. If you have a lot of back pain and several disc levels that are degenerated, your chance of getting better with surgery is much less. So I would caution you from that. But there are several treatments we have. The laminectomy and discectomy is just a way to remove bone or disc that's compressing on the nerve. And that's usually used for people that have mostly leg pain with some back pain, okay? The fusion is a technique that we use mostly for back pain. And what is a fusion? Well, when we fuse a disc level, what we're doing is basically eliminating the motion of that disc level and then connecting that vertebral body above and below the disc level. And that can be one-level disc fusion, two-level disc fusion, or multiple, depending on what your problem is. But in general, the less levels you fuse, the better chance you are of it fusing, and the better chance of getting better. So there are risk factors of fusion not working. If you're a heavy smoker, if you're diabetic, okay? Things like that you have to look into. If you're thinking about doing a fusion, the risks of fusion not taking can be worsened by those factors, okay? And there are several types of fusions which I'll talk about in a minute and show you examples of them in a minute, okay? So when we do a fusion, what we're doing is, again, connecting one bone to the other. And how do we do that? Well, we do that by using bone to connect that one bone to the other. And there are different types of bone grafts. If we use it from yourself, it's called autograft bone, okay? If we use it cadaver bone, it's called allograft bone. And in the past, we used to always use autograft if we could, okay? And usually the site we took the bone from was the hip. Not the hip joint, but the upper part of your hip where you feel back here. And that's the best type of bone to use as your own bone. But on the flip side, you can get a lot of complications and problems from that. Therefore, we tend to, over the years, have stopped doing that because we've got better fusion rates using allograft bone or cadaver bone and using instrumentation or screws and rods to hold things in place firmly to promote the fusion. PEEK just stands for polyethyl ethyl ketone, which is just a plastic. And that is a form of a structural graft that we use. So there are two types of grafts we use. One is a non-structural, which is kind of laid down, that connects the bones from one to the other, like for instance from one transverse process to the other. And then there's a structural bone graft that we use that goes into the disc space per se because it is going to be loaded with weight that we have to put something that's stronger. So that kind of bone graft is a structural bone graft. And we use instrumentation to hold things in place, and that creates a milieu that keeps the bones together firmly and promotes the fusion to taking. Now, one other treatment we've been able to do recently in the last 8 to 10 years is a disc replacement. And what is that? Well, we're not taking out the disc and replacing it with a brand new disc. What it is putting a prosthetic disc in that disc space. And this is mainly for that if we think that the person is having a lot of back pain from the disc itself. If you have normal joints, if you have no significant spinal nerve or cord compression, and you have mainly just back pain without much leg pain, then a disc replacement is possible. And it's only been allowed for people that are above 18 or less than 62. Okay, and that's for several different reasons. I won't go into today, but that's who falls in that category. And it's not a common thing that we do. And one of the reasons is also because a lot of insurance companies don't allow it to happen these days. I just want to mention the sports study, which was done, and I'm not saying this because I'm a surgeon, because the results were better in surgery, but for specific abnormalities, they reviewed several hundred people, okay, looking at whether they were treated non-operatively or operatively. And patients that had herniated discs with nerve pain did better overall than people that didn't have surgery. But after 2 years, everyone was about the same. But they had less time of pain and any other problems. With degenerative spondylolisthesis and spinal stenosis, again, those conditions we talked about, the surgical arm did better than the non-surgical arm. So in general, if you have what we talked about, these symptoms and signs and imaging studies consistent with this problem, then you in general do better with surgery. What are the type of surgeries we can do? Well, the fusions that we talked about, there's several different types. I'm not going to go into all these. There's a lot of names here. But there's an anterior fusion where you can come from the front of the spinal column. There's a posterior fusion which comes from the back of the spinal column. And there's a combination of both. There's a lateral fusion as well, and I'm going to show you examples of them all so you can see kind of what I'm talking about. And that's mainly what we do here in our office. There's a disc replacement, and a lot of the procedures that we can do these days can be done what we call minimally invasive. Okay? Now, you don't have to have it done that way. The standard procedures we do are excellent. I'll show you also that in a minute. But either way, it really depends on the individual, surgeon, and what their problem is, whether they can have a less invasive approach. The advantage of doing something minimally invasive includes that there's less tissue dissection and disruption. It's generally less painful. Shorter hospital stays occur. There's less blood loss, and usually can return to work or activities sooner. Not always, but it can. There's some disadvantages also, and that's because it takes a while to learn how to do this. The procedures are usually longer because you have to use a lot more instruments and use X-ray, and the radiation exposure a little bit higher. And some people say it's not as good as doing it regular surgery because your exposure is not as good. You don't see as much. And if that's the case, are you able to get an adequate amount of decompression or fusion bed preparation in this manner? But there are arguments on both sides, and I think both are right. Okay. And like I said before, you get the standard procedures like we always do. When I do a lumbar discectomy, for instance, if I'm doing a removal of a disc or removing some bone from one side or the other, my incision is very small. It's basically minimally invasive as well. So I think there are a lot of procedures you can do that way, which you don't really need to have a minimally invasive procedure. Here's just a schematic showing someone has stenosis, okay? So again, here's the spinous process and lamina, here's a spinal sac, and it's being compressed here. And this is something called laminectomy. So what you see, I don't know if everyone can see it, but here's now the disc in front, the bone that's in back, it's been removed here. So the spinous process and lamina have been removed, and that creates a larger opening for the spinal sac and relieve the spinal nerve compression. Okay, that's just a plain laminectomy. Now that can be done from either the left side or the right side. Now, if you're going to do a fusion, and again, I can't talk about the reason we do a fusion now with this talk, but if you're going to do a fusion, you can do it from the back side. But if you want to put something in the disc space, which is called an interbody fusion, because it's between the vertebral bodies, you have to move the nerves out of the way. So that's one risk of doing it from the back side, which you don't have coming from the front side, okay? But there are other risks coming from the front side. So if you go from the back side, it's called a posterior interbody fusion, or a PLIF. And so the next slide shows an x-ray of that. So what you see here is this person had the discs removed from the back side, and a piece of structural bone and non-structural bone was placed in the disc space at both the L3-4 and L4-5 disc spaces, and then screws and rods were placed to hold everything in place. And you can see here's a side view, and here's a front view. Now, when you do a posterior lateral fusion, you're connecting the transverse processes, and you can see here's a transverse process here, here's one here, and at the levels of the fusion, we're laying down bone to connect one transverse process to the other. And eventually, over time, and it can be a half a year, 2 years, that fusion forms, and you want to see basically one thick piece of bone connecting those together. This is now an example of a posterior lateral fusion. There was nothing put in the disc space, but there was something on the sides, which you won't see, which you'll see in the next x-ray. But this is also an anterior fusion, and you can see that we came from the abdomen this time. You can approach the spine from the front. By doing this, we move everything out of the way, the bowels and the blood vessels, and we go down there, and that decreases your risk of nerve injury, but it has other risks of injuring those structures in the way, like the bowels, the bladder, and those things. Uncommon, but it can happen. But that's a nice way of putting a nice big piece of bone in there to increase your rate of fusion. That's a side view. Here's a front view. Okay, and you can see again, here's where there's speckles of bone you see on the side that's connected to transverse processes. Here are the screws going into the pedicles, which I showed you before, and the rods, and they're connected by a crosslink to kind of make it very firmly stabilized. You ready? Here's just showing the inside of a body. You can see here, so the head would be up this way, the feet down this way. Here's the left side of the body, here's the right side of the body, okay? And you can see here is this remaining, here's the muscles being spread apart by a retractor, and here's the spinous process, and here's the spinal sac. And the next film, the next photo shows a higher magnified area. The spinal sac is here, the nerves are coming off, there's screws going into the bone, and then finally, they're connected with rods, okay? That's what it looks like. Now I'll just show you some examples of procedures that we've done. Here's a person who has got what we call a spondylolisthesis at L5-S1. You see the slip of the bone here. On the left side is the x-ray. On the right side is the MRI scan. You see the spinal nerves coming down, and there's really not much what we call stenosis or narrowing in the spinal canal. But if you look at the next study, which is the CAT scan, you see that compared, here's the foramen here where the nerve goes out at the level above, and here's the level below. Look how narrow that is compared to that one. See it over here? Here's the level above, level below. And that's because that slip of the bone. So what did we do? Well, I went anteriorly and put a nice big piece of bone graft, and you can see that I corrected that slip. And this is the CAT scan showing that, and here's a regular x-ray showing the bone graft in the disc space. I placed a screw to hold it in place in front, and then removed the bone over the nerves on the back side and placed screws on the back side. This is an example to show you how we can do this type of procedures minimally invasively, okay? So we can do it through a tube. So you can see that we just kind of spread the muscle apart, and we are able to kind of look through the tube and then remove some bone, and then let's say remove a disc, or remove the disc and replace it with a piece of bone. You can see here. And the next will be a view through what we see. So you see this tube is maybe about 12 millimeters in diameter, not very big. Are up to 18 or 20 millimeters in diameter. And you can see we have a microscope to look through it, which gives us a lot of magnification. It gives us a lot of illumination and magnification. So here's the disc removed. Here's the spinal sac with a nerve here, and this is a completed procedure. And you can put in bone grafts afterwards if you need to, and screws the same way with less dissection. And here's now an example of someone who had a inner body posterior fusion using that technique. Okay. Another technique we can use is a lateral fusion. Again, it's done minimally invasive. We make a small incision on the side, and the reason we do it on the side is that we are avoiding all these structures, the aorta, the vena cava, the kidney, and we come from the side to get to the front of the spinal column. Okay, so we're avoiding going from the back side, which can hurt the nerves. We're avoiding the front side because we don't deal with all this stuff here. So we come from the side, and we do it through a tube again. You can see here's now the person's on their side. Okay, and we place probes down to get to the right spot. We use X-ray to make sure we're in the right spot, and then we put this retractor, and then we work through a small tube, and then we remove the disc and replace it with a cage. And here's an example of one of those PEEK cages that we fill with bone, and that's used as a bone graft and a stabilizing factor. And you can see here we work through this small hole through this retractor. Okay. This is an example of one of my patients. I did the operation about a month ago. You can see that before surgery, she had a slight slip of the bone here. She had a previous fusion. She did well with this at L4-5. And then at L5-S1, at L3-4, you see that there's a significant slip of the bone. Well, after surgery, I did one of those side operations. I put that bone graft in there, and look how nice. It looks like a normal spine again. There are a lot of other procedures that I could mention. I'll just mention one more, and this is called an axial lift. This is one way that my partner, Dr. Kunwar, does fusions at L5-S1. And he makes a small incision just in the area above the buttock crack, and dissects through the tissue and gets in front of the spinal column here, and this is all done through a tube, and he's able to place this screw through the vertebral body of S1 to L5, and then do a fusion that way. And there's much less dissection, and patients do very well with that as well. This is just to show you what it looks like if you have just a discectomy with an open approach. This is a patient of mine that I did an operation where I removed bone at 2 levels, L4-5 and L5-S1 on one side, and you can see that the incision was only about 3 centimeters. Okay. I want to show you about the disc replacement. Again, this is for people who have mainly back pain from what we think is just degenerative disc disease without leg pain. This is one of the prostheses. There's several out in the market now, but you can see that it's not a disc. It's 2 pieces of metal with a polyethylene core. And the reason that we try to do this, especially in a younger population, is that it avoids the risks and problems in the future with a fusion. And what is that? Well, a fusion fixates the spine. Okay? It doesn't let you move anymore. So you lose some range of motion. The more levels you fuse, the less range of motion you'll have. The disc replacement is to allow you to get relief of the pain, but not to lose your range of motion. Okay? Also, if you have a fusion, over the years, that fusion adds stress to the disc levels above or below the fusion site. And therefore, that can cause problems and perhaps require those disc levels to need surgery sooner than later. So the reason for the development of this product was for that. And this is just an example of what it looks like when you're in a example of how it looks like in the body. And here's actually an X-ray showing a disc replacement at the L4-5 level on the side view. This is not just an X-ray just showing the compression fracture. We can also do somewhat minimally invasively. We just use it, again, through tubes. And people that are the older population that gets soft bones or osteoporosis can develop compression fractures. This is a side view, again, showing a relatively normal-looking vertebral body. And here's a compression fracture. It goes from looking like a rectangle to a triangle. We're able to put in, through tubes, cement to stabilize that fracture and makes it feel less painful. And there's a technique called a kyphoplasty, where you inflate a balloon in that soft bone. It creates a void, and then in that void you place cement. And the reason to do it this way, as opposed to just a regular vertebroplasty where you just inject the cement, is that they say this helps correct that compression. You see this looks like it's gotten more close to looking like a normal rectangle, because this helps alleviate that. And also, you don't put the cement in under any other pressure. So here's a view after surgery which shows that the bone is filled with cement. So in conclusion, low back pain is a very common problem. Almost everyone in this room is going to have some episode of low back pain, and about 10% of us are going to have chronic back problems, okay? Most of us get better with time, whether it's with medications, therapy, some of us need injections, and less likely surgery, but there are a lot of treatments available. Most treatments are non-surgical. There are plenty of surgical options, but you really have to be someone that fits the bill and the categories that make you the highest chance of improving before proceeding with it. Okay, thank you.